Okay, thank you. Good evening, everybody. Welcome to our free webinar session series by More Education. Today we are going to discuss about the medical statistic and epidemiology. This is a very hard topic for all of us. We could have struggled more during our medical student period. Today we are having a great resource person. He will teach us regarding medical statistics and epidemiology in a easy way, and you everybody will understand very much. It is our privilege to introduce our resource person, Professor P. Kumarendran. He qualified from the University of Jaffna, and he proceeded his MSc in Community Medicine and MD in Community Medicine in University of Colombo, and he completed his FRSPH as well. He is now the chair professor of Community Medicine and specialist in Community Medicine, Faculty of Medicine, University of Jaffna. I kindly call you, sir, to deliver your lectures on medical statistics and epidemiology. Over to you, sir.
Thank you very much for the kind introduction. And can you hear me clearly?
Yes, sir.
Right. Okay. So that today we are going to discuss about screening test, and I know the conducting the classes via Zoom is somewhat different when compared to the classes in person. So in that case, if you can't hear me clearly, or if you have any issues with the technical aspects, and you can feel free to let me know via the chat so that we will proceed. Screening test. So screening test is one of the important components which are asked in many exams. So that it's good to know about screening test, and for your clinical practice also, the screening test is very important. So in that case, we'll proceed. Okay. So what do you learn from this picture? Anyone who want to put any chat message? What do you learn from this picture? Anyone? Anyone you want to let me know, because teaching should be interactive rather than having a unilateral or one-way communication. Anyone, if you want to put in a chat message, what do you learn from this picture?
They are trying to clean up without stopping the tap.
Yeah, because when you consider without finding out the root cause, if you try to, so like that, for that, whenever you get the diseases also, patients, so what do you need to do? You have to find out preventing the more and more people getting the disease rather than actively treating the patient. Do you agree with me, right? So that we will see that how the screening would be helpful in achieving the task. Okay, right. So in that case, we'll see the levels of prevention, because when I cover different components, having your exam in mind, so that they will also link the questions, the screening with the levels of prevention, right? So when you consider levels of prevention, and how do we categorize the levels of prevention? Better have the chat message, because if many people start to discuss, it will be clashing. Okay, so when you consider the levels of prevention, we basically categorize levels of prevention into three. So that is the primary prevention, and secondary prevention, and tertiary prevention. So we can also further subcategorize the primary prevention into primordial prevention. So that basically three levels of prevention are there, and we further categorize the primary prevention into primordial prevention. So can anyone put it in the chat message, what would be the basis for us to do this categorization? Anyone? What may be the basis for us to say a particular activity as primary prevention, another one as secondary prevention? What may be the basis? Because you have to feel free to communicate, otherwise what will happen, you will lose a chance to identify what errors you make. So that rather than always listening or rather than always reading, Yeah, and you should be mindful about the mic also, all right? Okay. Whenever there are background noise, so that the moderators would look into that. Okay, right. The outer mass occurred or not. So when we consider the primary prevention, the whatever activity we do, right, before the infection or before the injury or before the insult. So before any harm take place to our body or before any infection take place, if we do any activity, and that is called primary prevention. Okay, someone's mic is on. So I think the moderators will check whose mics are on, and whoever mic on, their name will come on the top so that you can mute them. Okay. So in that case, what is secondary prevention? The secondary prevention and tertiary prevention are after getting the infection or injury or insult. So that both are after the getting the infection or injury, right? So in the case, the primary prevention, that means at a reversible stage. If you do any activity after getting the infection or after getting the disease, at a reversible stage. But the tertiary prevention is at a irreversible stage. So for example, if you consider, someone fell in love, so that the parents or somebody try to do anything, try to separate them at the initial stage. At the initial stage, they may be at the reversible stage, right? So when you say we have found a partner with a very good dowry, when you have found a partner with a very good job, and when you have found a partner in this condition in Sri Lanka, having a foreign citizenship, so it is irreversible, right? Okay, your decision may be reversible. But when we come to the tertiary prevention, so that's about irreversible. That means you can't fully revert back, but only thing you can do is, while having some permanent issues, you can try to overcome that. So that is tertiary prevention. So in the case, if I ask a question, the screening, is it a primary prevention or secondary prevention or tertiary prevention? That is one of the common questions they ask in the exams. So screening is categorized into which type of or which level of prevention. Your answers in the chat message, please. Around 3 or 4 people have given the answer. We are getting the mix of primary and the secondary, right? We are getting the answers mix of primary and secondary. Okay. The answer is the secondary prevention, right? Secondary prevention. So we'll see, why do we say this is secondary prevention after a while, right? Why do you say? Because if you want to screen for a disease, then what happened? Before the development of disease, if we consider the conventional methods, it's unlikely. Because if you want to diagnose the diabetes, what happened? You need to see that there should be some abnormal glucose level. So there should be some sort of abnormality, right? So without that, so before the development, so that what we can do, we can diagnose. So in that case, the screening is categorized into a activity of secondary prevention. So can anyone tell me what is the gold standard example of primary prevention? Any gold standard example for primary prevention? Anyone? Can you put in the chat message? Yeah, very good. So whenever you put the answer, better you put it in the private chat message so that it will give the opportunity for others also to answer. The immunization, because immunization, when do we give the immunization? After developing the illness or before developing the illness? Actually, ideally, before developing the illness. So when you consider the primary prevention, the immunization is an example of the primary prevention. Okay. So what would be the ideal example for tertiary prevention? Anyone? Tertiary prevention, or what sort of activities collectively we claim as tertiary prevention? Anyone? Rehabilitation. Ideal thing is rehabilitation, right? So we call it rehabilitation. So that what do we want to learn? The screening is an activity of secondary prevention because we want to do it in a reversible stage after developing the illness. Okay, we'll move to the next one. So when you move to the next one, so here we can see the natural history of diseases. So this is the other concept you need to know whenever you come across any questions in relation to screening, because they put some questions in relation to the natural history of diseases. So when you consider the natural history of diseases, in the left side, the time starts and the time moves towards the right side. And here we can see initially the biological onset of the diseases, right? The biological onset of disease, right? So when you consider the biological onset of disease, what did we say is, because the primary prevention is before this. After this, secondary and tertiary prevention. So that after the biological onset only, you will be able to diagnose using a screening test. So in that case, usually the people will develop the symptom. Do you think immediately the people will develop the symptom? No. When somebody fell in love, do you think that immediately the changes start? No. Because whether immediately the parents come to know? No. After a couple of time only, they come to know our son or daughter is spending more time with the mobile phone. Earlier, not bother about the hairstyle. Now, much care about the hairstyle. Earlier, not bother about the dress. Now, putting a dress, then looking at the dress, then again changing the dress, you know. And earlier, the telephone bill was very less. Now, every week, the person has to pay the telephone bill. So like that, those symptoms will come to the parents will come to know of the symptom, but after the gap. So that in the disease also, after the biological onset, we don't immediately develop the symptoms, and there will be a phase, we call it preclinical phase. We call it preclinical phase. And the phase after the development of symptom, we call it clinical phase. So this is preclinical phase. Pre means before. So this is a preclinical phase. So when you consider the preclinical phase and you get the biological onset of the disease, then you develop the symptoms. And do you think that all the people immediately look for the diagnosis? No. What happened? They will observe and they will take, right? They will think, okay, so this will cure on its own. They may say this may not be that disease. This may be some other thing, right? And then even if they have some suspicion, they will need to, find out the date and then find out the availability of the consultant or somebody. So that the diagnosis, this is a diagnosis. And how do we call the time gap between the phase that is detectable by screening, so that you can detect by the screening, and the usual diagnosis, and that is called lead time. So that in the questions in relation to the screening, one of the questions you get is related to the lead time. So in that you need to have a clear idea what is meant by lead time. So the lead time means the gap between the timeline where you can diagnose, where you can detect a condition using a screening, and the gap between the usual diagnosis, that is called lead time. So that, how do we call this phase? The detectable preclinical phase. So that when do we apply the screening? We apply the screening in the detectable preclinical space. So that in CQ, you get a question, that possible time to apply the screening. So that is detectable preclinical phase. Okay, now we have some idea. So we'll move forward, right? Okay, so there may also be some questions about detectable preclinical phase. So that we will see some aspects in relation to the detectable preclinical phase. So that one is, without the screening, the diagnosis may occur only after the symptom, usually. But the disease may have developed even before the development of the symptom. So even in the absence of symptom, there may be a point in which the disease could be detected by the screening test. And that one we call detectable screening preclinical phase. If you get an MCQ, the screening is applied in symptomatic persons. True or false? What do you say? Screening is applied in symptomatic patients. True or false? What do you say? Please put private chat message, not to everyone, because when you put to everyone, the people, the others will lose a chance to infer. Yes, majority have given the correct answer. The screening is expected to be applied in apparently healthy people. How do you call that? Apparently healthy people. What is meant by apparently healthy people? We assume a person is healthy, not yet diagnosed to have a disease, but the person may be having the disease. So that screening is not applied in symptomatic people. Symptom which is suggestive of a particular condition. So how do we call if a person present with the symptom? If you diagnose a disease, how do we call that? If a person present with the symptom suggestive of a illness, you diagnose an illness, how do we call that? Is it screening? Is it something else? How do you call that? Anyone? Or if you don't know, you have to say don't know. Don't keep your brain unused, and don't think that if you keep the brain unused and we can better use it in the exam, that will never happen, right? Okay. That is case detection. What is that? Case detection. What is case detection or case identification? Because what do you do? Because you identify the case, not screening, right? Okay. So now what we have seen is the detectable preclinical phase, that is during the asymptomatic and before developing the symptom. So screening is applied in asymptomatic people, right? Okay. So we'll see some examples. So for example, cervical cancer screening, right? When you consider cervical cancer screening, so here you can see it develops very slowly. It takes around a decade, and also takes longer time to become invasive. So in that case, you have a great opportunity for you to detect even before they develop the symptom. And you have a possibility, you have a phase where you can screen the people for cervical cancer. Okay, so we'll move forward. So what is a screening test? So in the case, what is a screening test? So screening test differentiate apparently healthy but disease individual. That is very important. So on whom you apply the screening test? On apparently healthy people but disease individual. From those that probably do not have the disease. Probably do not have the disease. Why do we say probably do not have the disease? Anyone, can you tell why do we say probably do not have the disease? Anyone? But why we don't say people do not have the disease? Why do you use the term probably do not have the disease? Anyone? Please give some task to your brain. Yes, because in a screening test, when you say a person is not positive for a screening test, a person is negative for the screening test, that doesn't mean the person is not having the disease, right? When the screening test claim that a person is not having the disease, that doesn't mean the person is not having the disease, because there can be a false negative. So that we will discuss later. So that's why we say a screening test differentiate apparently healthy but disease individual from those who are probably do not have the disease. Okay. Now we'll see what are the implicit assumptions in the concept of screening, right? What sort of implicit assumptions we have? One is early detection before the development of the symptom, because we apply the screening test in the people who before develop the symptom, will lead to a more favorable prognosis, right? So if we detect the people before develop the symptom, so there is a favorable prognosis. That is one assumption. So that there are also, the assumption may not be true in some circumstances, we will discuss later. So if we consider that, and why does a screening test require a rigorous evaluation, right? Okay, so why do we need to have a rigorous evaluation of a screening test. One thing is there, we need to convince the benefit outweigh the risk and the cost. So benefit of the screening should be more than either a risk of undergoing the screening or risk of undergoing the diagnostic test or the cost of undergoing the diagnostic test or cost of undergoing the screening. So in the case, what happened, we have to compare the risk and the benefit, right? So what sort of things we consider in the benefit? The early detection and the early treatment should improve the prognosis, right? So that is the benefit we look for. And what aspects we consider in the risk or cost? Because maybe it's associated with the screening, or maybe it should be associated with the consequent, but the diagnostic procedures. We will discuss that in detail later. Yeah. Okay. So that we will, when you come across the questions in screening, you will be coming across two aspects. One is about disease characteristics. Some questions you may come across about disease characteristics, and some questions you may come across about the test characteristics. So that first we will look into the disease characteristics. After learning the disease characteristic, we can learn about test characteristics. So in the disease characteristics, one of the aspects is, right, in the disease characteristics. So one of the aspects is the disease should be serious disease. It should be serious disease. So do we apply screening test to identify common cold? No, because a common cold is not a serious disease. Because when we apply a screening test, there are a lot of cost and resources involved. So there should be a cost benefit. So in the case, the disease should be a serious disease. Say, for example, cervical cancer is a serious disease. So in the case, we can apply a screening test for that. Other thing is there, when the treatment before the symptom occur should be more effective than the treatment delayed until the symptom develop. So we will look some example later. And the disease characteristic is when the prevalence of disease in the detectable preclinical period should be higher. So that also we will discuss later. So that the prevalence of the condition in the detectable preclinical phase should be high. By this criteria, the blood pressure screening to detect and to treat the hypertension is an ideal example of screening. So we'll see why it is, right? We'll see why it is. We'll see that later. Okay, right. Sorry. Right. So now we'll see the disease should be serious. Why? Because we have to consider the ethical aspects. One thing, the cost effectiveness, right? So we have to check the cost of the screening against the cost of the morbidity and the mobility, right? Other thing, ethical aspects. So the consequence of missing the diagnosis and versus the risk of discomfort due to the screening. All these things we have to compare, right? Other thing, this aspect we discuss. Okay, we'll move to the next. The life-threatening disease. Say, for example, the breast cancer. The condition may be a life-threatening disease. The other characteristic of the disease would be the disease with serious and irreversible consequences. If you fail to pick up the illness at the earliest stage, the consequences may be more severe. For example, the congenital hypothyroidism. Congenital hypothyroidism, if you fail to identify early, the consequence for the child will be severe. Phenylketonuria, if you diagnose early, so that you can alter the diet, and then what happened, the quality of life of the person would be greatly improved. So these conditions, if you fail to identify early, then the consequences will be more harmful, and sometimes it is irreversible. And then the other aspect is there, a test may not be needed to screen. Say, for example, if you consider the non-melanotic skin cancer, right? Because the condition may be curable, completely curable, even if you detect after the development of the symptom. So if you consider the non-melanotic skin cancer, so there's a possibility for a complete cure even after it becomes symptomatic, so that you don't need to bother to diagnose it, or you don't need to bother to detect that at the detectable preclinical phase. Other aspect is there, the screening the high risk group. So it may be more cost effective, right? So for example, if you consider the bladder cancer, so some occupational groups, if you apply the screening, it will be more cost effective. So for example, most of you are very fond of wearing the denim jeans, but if you consider the dyeing, it's very harmful. So the people who are the garment factory workers who involve the dyeing, they are at a high risk of getting the bladder cancer. So those who deal with the dye. So in the case, what you can do, rather than applying the screening test for bladder cancer in the general population, if you apply it in the occupational category, so that it will be more cost effective. So for example, the breast cancer, if you apply in the woman who has a strong family history, again, it should be more cost effective. Okay. Now we will discuss the other aspect, the why hypertension is ideal for screening, right? Why hypertension is ideal for screening. So for example, if you consider, one is hypertension is a serious illness, because if you fail to detect, it can end up in stroke and there can be more consequences. So there are greater mortality in the hypertensive individuals, and the mortality increases with the increase in the blood pressure. So in the case, it's good to detect early. And the early treatment has shown reducing the consequences. And the other thing there, earlier we had discussed about the prevalence of illness in the detectable preclinical period. And here, if you consider the hypertension, the prevalence of hypertension in the detectable preclinical period is higher. If you consider the hypertensive people, nearly only 1/3 is diagnosed. Around 2/3 of the hypertensive patients are not diagnosed because it's an asymptomatic condition. You may develop the symptom when you get the complications. Okay, so for those reasons, the hypertension may be more suitable for applying the screening. Okay, right. Now, if you see the phenylketonuria, right? If you see the phenylketonuria, so the screening test may be useful, though the disease is very rare, right? Though the disease is rare, because earlier we have seen that applying the screening test is ideal in more prevalent cases, but the screening test can also be useful in some conditions where it may be a rare condition. So for example, phenylketonuria, where if you fail to detect early, there can be very serious long-term consequences, right? And also there is an option to improve and prevent the mental retardation if you introduce the dietary intervention soon after. And also in the phenylketonuria, there's an availability of simple test, accurate test, and relatively inexpensive screening test. So that's why in some circumstances, though the condition is rare, but use of a screening test would be useful. Okay, we'll move forward. So does the screening always appropriate, right? If we see whether the screening test is always appropriate. So for example, if you consider gallstones, in anatomy you may have learned, or in surgery you may have learned, because many people may have gallstone, right? But the thing is there, it will remain asymptomatic. So usually you don't want surgery, right? But if you want unethically, earn from the people, then you can say, look here, there's a gallstone, it's a big stone and we had to operate and you can earn money, right? But it's unethical. So in that case, if they become symptomatic, what you can do, you can remove the gallbladder, and also you can delay the treatment. Generally, even if you delay the treatment, it will not cause much problem. So in that case, you don't want a screening test to diagnose what? The gallstone or detect gallstone, right? If you consider the lung cancer, even if you diagnose the lung cancer using a screening test, even the earlier treatment doesn't seem to prolong the survival. So that one of the aspects we have seen for a disease characteristic, if there should be a possibility to prolong the survival. If you screen, there should be an option to improve the survival. If there is no improvement, sorry, the sharing is stopped. I will share it again. If there is no option for improvement, then no point of screening. And because screening may be very inefficient when the prevalence of the condition is very low. So that also we'll discuss later when to do some calculation. Okay. So what we have seen now is about the disease characteristics. So what we are going to see further is about the test characteristics, right? Test characteristics. One thing, if you want to apply a screening test, there are two requirements are there. Basic two requirements. What are the basic two requirements for a screening test? One is there should be a diagnostic test to confirm the disease. Because in the screening test, what you can do, you can suspect the presence of the disease. You can't confirm. But here, what you need to do, you need to have a diagnostic test. So for a condition, if you don't have a diagnostic test, no point of applying a screening test. That is one. The other aspect is there should be availability of treatment option to prolong the survival. So for example, in lung cancer, there are no much screening tests for lung cancer because even if you diagnose, the possibility of prolonging the survival is lesser. Okay. What are the other additional features, right? What are the other additional features of a screening test? The characteristic of a good screening test, right? What are the other good characteristics of screening test? There are a couple of A's are there, right? A couple of A's are there. One thing, it should be affordable, right? It should be less cost, affordable. Other thing is acceptable, minimum discomfort. It should be acceptable, right? It should be acceptable, right? And then availability, right? It should be available to many people. It should be accessible, right? Relatively easier, right? Accessible in the sense it can be cost-wise, it can be physically accessible, right? And administer easily. Even you should be able to do that in a field setting or in a community setting. So you should be able to administer easily. So the screening shot should not require high technical input. Even a person who is less technically sound should also be able to do that. So that's why nowadays to detect the blood pressure, even you can check the blood pressure at home. The fingertip glucose testing, capillary blood testing, blood sugar testing. So administer easily, right? And reliable. Reliable in the sense when you repeat, it should give the same finding. Consistent finding. So that is the reliability. So what is reliability? So when you repeat, it should give the same finding or consistent finding. And the valid. So these aspects are asked in the exams frequently. So you should have some idea what is meant by reliability and what is meant by validity. So what is meant by validity? So that should identify what you ideally intend to do. So we can see that using a diagram easily. So for example, if you see this diagram, just take a couple of seconds to go through this diagram. Okay, so here you can see in this picture. So in this picture, you can see what happened. The dart hit relatively closer to single point. But what is our expected point? We expect the dart to hit this, something like this diagram, the right diagram on your right, the right extreme. So we expect something similar to this. But here you can say it is hitting, if you expect another dart, it may also hit somewhere closer to this. That is called reliable. So when you say reliable, in a repeated observation, you are getting the same finding. So that is reliability. But though it is reliable, but the finding is not valid. Why do you say valid? because we expect to hit this point. We expect to hit this point. Say, for example, in an exam, cutoff marks is 50. And repeatedly, you are getting 40 marks. So if you are getting another exam, someone can say you may get 40. Sometimes the answer may be reliable, but it may not be valid. Why? Because you are expected to get marks more than 50. So when we consider in this situation, the second situation from the left, what happens is low reliability. Why? Because the darts are not hitting the same point. And it's low validity also. Why? Because darts are hitting away from this expected target. But here you can say what? Not reliable and not valid. And here you can say reliable as well as valid. So this is about validity and reliability in the screening test. So that what are the measures of validity in a screening test, or what are the measures of the accuracy in a screening test? So these two are the measures of validity or measures of accuracy in a screening test. One is sensitivity, other one is specificity. Sensitivity and the specificity. So these are the one of the more common aspects in the questions. So you need to have a clear idea about what is sensitivity and what is specificity. So here sensitivity, the ability of the test to identify correctly those who have the disease. If you apply the test among the people who are really having the disease, and how many people the test will correctly identify as having the disease, there is sensitivity. And what is specificity? So when you subject the people who do not have the disease, and your test should correctly identify as not having the disease. Correctly identify as not having the disease. So we can see that using a table. We look at this table. So that sometime in the questions, they will not fill this table. They will give a story. They will say there were this number of people having the disease and we subject the screening test. And then this number of people are positive for screening test. This number of people are negative for screening test. In the case, you need to have the ability to fill this table, right? And someday you may have to draw this table your own. So how do we create this table? What aspects we have to look into in this table? Conventionally, we put the diagnostic test or gold standard at the top. Conventionally, we put the diagnostic test, gold standard or reference test at the top. So that the diagnostic test findings we put vertically. Diagnostic test finding we put vertically, right? We put the screening test results horizontally, right? Horizontally. So in an exam, sometimes you will get confusion. In an exam, you may get confusion. How do we remember that easily? In alphabet, the D come first, S come later. So we put the D on the top, S later. That is one of the aspects. Other thing, the diagnostic test, we put a higher place for the diagnostic test. So that we put the diagnostic test here, screening test here. So here, what do we do? Can you put in the chat message? Who are really having the disease? Private chat message. Who are really having the disease? Private chat message. Okay, private chat message, because not A, because the people who are having the disease is what? A and C. A also having the disease, A also positive for diagnostic test, C also positive for diagnostic test. In the case who are really having the diagnostic test positive, A also having the diagnostic test positive, C also having the diagnostic test positive. So A plus C. Who were excluded from having the disease? Who are excluded from having the disease? Private chat message, please. Who are excluded from having the disease? Okay, very good. So you have to put either B plus D or you have to put B comma D, right? Either you have to put B plus D or you have to put the B comma D. Okay. So these people are what? Negative for diagnostic test. Negative for diagnostic test, right? Okay. Can you put it in the chat message? Who are positive for screening test? Who are positive for screening test? Listen carefully and answer, please. Who are positive for screening test, not the diagnostic test. Who are positive for screening test? Okay, the A and B. A is also positive for screening test, and the B is also positive for screening test, right? A is also positive for screening test, and the B is also positive for screening test. So these two are positive for screening test. Who are positive for, sorry, who are negative for screening test? Private chat message. Who are negative for screening test? Okay, most of you give the correct answer. The C and D are negative for screening test. C and D are negative for screening test. Okay, right. Can you put the equation for prevalence of disease? If it is done in a community-based situation, if this describes the community-based random sample, community-based random sample, can anyone put the equation for prevalence of this disease in this community? Prevalence of disease. What is prevalence of disease? The number of people having the disease, and the denominator is all the people. Kindly put the private chat message. Please kindly put the private chat message. And in this IT era, you should know how to put a private chat message, right? Okay. So A plus C divided by A plus B plus C plus D. Because A plus C is the people who are really having the disease. And all the people at risk is what? The A, B, C, D. Right? A, B, C, D. Right? So in the case, so that you may also get such a question, right? In a random sample, in a community-based sample, so that if you apply this one, so what would be the prevalence? Okay. Now you put it in the private chat message. If you find it difficult to learn the private chat message, better not to put, right? Because it's unfair for the other students, right? So what is true positive? Which is indicated by true positive? Which is indicated by true positive? True. When we urinate, we don't urinate in the public. We go to a private place and urinate. And some people want to urinate in the public, right? Can't help, right? After repeatedly telling, right? Which is true positive. Okay. I will ask the next question. which is true negative? Which is true negative? Okay, I know that some of you have some doubts, so that we'll discuss it further, right? We'll discuss it further. And how do we decide on the true positive and true negative, right? How do we decide on the true positive and the true negative? So I have written here true positive, false negative, true negative, right? False negative and true negative. In that case, the whether it is positive or negative, how do we decide whether it is positive or negative based on the screening test finding? So we claim a test is positive or negative based on the screening test finding. We claim whether a test is true or false based on the diagnostic test finding, right? We claim a test is true or false based on the diagnostic test finding, and the positive and negative based on the screening test finding. So how do we remember that whether true or false is from diagnostic, whether positive and negative is from screening? How do we recall? Better to have some mnemonics, better to have some tricks to remember this. If you consider diagnostic test, if you consider screening test, which come first in the alphabetic? The diagnostic come first in the alphabet. The D come first in the alphabet. S come later in the alphabet, right? So since D come first in the alphabet and S come later, so that the true or false is from the first thing is true or false, that is from diagnostic test, and the positive and the negative is from screening test. Now we'll go to the table and see that. Now we'll come to this table and look at. Now here we can say, if we consider this one, A, so whether positive or negative is based on what? Screening test finding. So A, screening test positive. For B, screening test positive. For C, screening test negative. For D, screening test negative. So whether it is positive or negative, that is determined by the screening test finding. Now we'll see, when the screening test say it is positive, whether diagnostic test is also saying positive. Yes. So screening test also saying positive, diagnostic test also saying positive. Both are saying the same thing. So what screening test saying is true. So it is true positive. Now we come to the C. When we come to C, the screening test is saying negative. When the screening test is claiming negative, the diagnostic test is claiming positive. Contradictory. So this is negative, this is positive, contradictory. So we say false negative. False negative. And then if you come to C, B for butter. When you come to B, here we can say the screening test claim it is positive. When the screening test claim it is positive, the diagnostic test is negative, contradictory. So it is false positive. Screening test is claiming positive, but it's not really positive. So it is false positive. Here we can say D, screening test claim it is negative. Diagnostic test also claiming it is negative. Both are claiming the same. So it is true negative. True negative. So in that case, which is sensitivity? Sensitivity is true positive. So you make it a question. Sensitivity is the true positive rate. That is true. You may get a question. Specificity indicates true negative. That is true. specificity indicates the true negative. That is true. So here we have given the fraction here. So sensitivity is A over A plus C. Specificity is D over B plus D. And the false negative. So this is false negative. The false negative is C over what? A plus C. False positive. B over B plus D. Anyone having doubt, you can put in the chat message. Anyone, if it is not clear, if it is ambiguous, you can put a chat message. Anyone? Is it clear? Shall I proceed? Oh, otherwise you have fell asleep. Okay. Since one or two people have mentioned that they need time, so that I will quickly tell that. So A, we claim true positive. Why do you say true positive? Screening is also positive. Diagnostic is also positive. Both are positive. So we say true positive. This one we claim true negative. Why do you say true negative? Screening test also claim negative. Diagnostic test also claim negative. Both are claiming negative. True negative. This is false positive. Why it is false positive? We decide positive based on the screening test finding. So in the screening test finding, it is positive. So it is positive. Then we had to look what is the decision of diagnostic test. When the screening test say positive, diagnostic test say claim negative, contradictory. So we say false, because the diagnostic test finding is what? The trustworthy one. So it is false positive. Here we can say screening test say negative, so that is negative. When the screening test say negative, diagnostic test positive. Ideally, they should have been positive, but the screening test say negative. So we say it is false negative. Okay, we'll do some examples. If you have problem, we can learn it later. Right? We can learn it later. Now we'll say, if you see this table here, the screening test say the 90% or 90 people are positive, and here 10 people, here 10, here 40. And how do we calculate the sensitivity? The sensitivity is what? A over A plus C. The total is 100. So in the case 90 divided by 100, that is sensitivity. What is specificity? Here you can say this is specificity. This is specificity. D over B plus D. Here we can say D is 40. 40 divided by 50. That is 80. Now we will say, when you consider A over A plus C, do we calculate vertically or horizontally? Okay, so there's a question, why A to be divided by A over A plus C, right? Okay, because when A over, because we'll see this. When you consider this, who are really having the disease? Who are really having the disease? A plus C are really having the disease. When A plus C are really having the disease, the screening test identify only the A as having the disease. That's why for sensitivity, we divide A divided by A plus C. For specificity, D over B plus D. Why do we divide D over B plus D for specificity? Because who are really not having the disease? B plus D is not having the disease. When the B plus D is not having the disease, screening test claim only the D is not having the disease. That's why D over B plus D. Clear or not clear? Right? Okay. So in that case, here you can see A over A plus C. Do we calculate A over A plus C? When you consider A over A plus C, is it calculated vertically or horizontally? Others, A over A plus C, is it calculated vertically or horizontally? You can put V. If it is horizontally, you can put H. It is vertical, right? A over A plus C, we calculate vertically. Now we'll see B over B plus D. B over B plus D. Is it calculated vertically or horizontally? Okay, it is vertically. It is vertically. So that is the other aspect you have to consider. The sensitivity also we calculate vertically, and specificity also we calculate vertically. Now, if you see that whether decision taken vertically are trustworthy or decision taken horizontally are trustworthy, what do you say? Anyone? Decision, you can put answer VOH. Decision taken vertically are trustworthy or decision taken horizontally are trustworthy? Why do you say decision taken vertically are trustworthy? Anyone? Why do you say decision taken vertically are trustworthy? Because the decision taken vertically are based on which finding? Diagnostic test finding. Decision taken vertically are based on what? Diagnostic test finding or gold standard finding. So that's why it is more trustworthy. Okay, it's trustworthy. Now we will see what do we calculate using the screening test finding. What do we calculate using the screening test finding? We call it positive predictive value and negative predictive value. Positive predictive value and negative predictive value, right? Positive predictive value and the negative predictive value. How do we calculate, right? How do we calculate, right? Okay, how do we calculate positive predictive value? That means when the screening test say 100 people are positive and who are really positive. What is negative predictive value? When the screening test say 100 people as negative who are really negative. So in that case, here what do we do? What do we do? 90 divided by, that is A over A plus what? B. This is what? D over C plus B. So in that case, right? Okay. So positive predictive value, how do you calculate? A over A plus B. Negative predictive value, how do you calculate? D over C plus D. In that case, positive predictive value and negative predictive value, how do we calculate? Vertically or horizontally? It is horizontally, not vertically. It is horizontally, right? So that you need to have a clear idea. You need to have a clear idea. Sensitivity and specificity, we calculate vertically. Positive predictive value and negative predictive value, we calculate horizontally, right? We calculate horizontally. So which is more trustworthy? Sensitivity and specificity is more reliable, or positive predictive value and negative predictive value is more valid? Which is more valid? Sensitivity and specificity. Why so that you make it an MCQ, you make it a question. When the prevalence changes, when there's a change in the prevalence, which will be more constant, the sensitivity will be more constant, even if the prevalence changes. Specificity will be constant, even if the prevalence changes. What will happen to the positive predictive value, right? If you want, I can take a, I'll share this. I can take a blank slide and explain. Okay, I will open a blank slide. New slide. Okay, so in this one, I'll try to explain. Say, for example, when you consider sensitivity, right? When you consider sensitivity. So sensitivity we have seen, that is, sensitivity. Sensitivity we have seen A divided by A plus C. So in that case, here, that means what? 90 divided by 100. Okay, 90 divided by 100. So in that case, if we see that, who are these 90 and who are these 100? These 90 are what? Screening test what? Test positive. Right? And these 100 are what? Who are A plus C? Those who are really positive for disease. That means you want to see what? The diagnostic test positive. Diagnostic test positive. So that means if you subject this screening test among 100 people who are having the disease, the screening test will identify 90 as having the disease. Okay, so if you want, I will write it here, right? If 100, if this screening test, okay, if this screening test is applied among 100 patients or 100 persons confirmed to have disease, what do you want to say? This screening test will identify 90 as having disease. Is it clear or not? Anyone? What do you say? When we say sensitivity, if the sensitivity is 90%, what is meant by sensitivity is 90%? If you subject 100 people who are really having the disease, this test will identify 90 people as having the disease. So that is sensitivity. Okay, that is sensitivity. Now we will go to another slide. Okay, we'll go to another slide. So what is specificity? We'll see what is specificity. Specificity. So when you say specificity, I put the abbreviation SP, but it's not a standard abbreviation. So that if you consider 80, that means what? D over, right? B plus D. D over B plus D. So when it is D over B plus D, that means what? D divided by 100. So that in that case, how I can say, if this test is applied among 100 people excluded for having disease, or right, you can say what? Negative for screening test. Sorry, diagnostic test. Negative for diagnostic test. 100 people who are this one. This test will identify 80 as what? Anyone put in the chat message? This test will identify 80 as what? Quick. Very good. Right? Identify 80 as negative for screening test. Screening test. Negative screening test. Is it clear? So this is specificity. So what is specificity? When you subject the test for the people who are negative for disease, if you have subject 100 people, how many people will be identified by this test as negative? What is specificity? When you subject this test to 100 people who are having the disease, and how many people will be identified by this test as having the disease. Okay. So again, we will learn about other aspect. I'll put another 2 slides. Okay. We'll see what is meant by positive predictive value. Right? What is meant by positive predictive value? So we'll take the previous results. The positive predictive is 90 here. Right? Okay. The positive predictive value is 90 here. So if the positive predictive value is 90, so how do we interpret this? So positive predictive value, we calculate what? Horizontally or vertically? We calculate horizontally. So in the case A over what? A plus A over A plus what? B. So in the case, if it is A over A plus B, so how do we interpret this? And if the positive predictive is 90, what do we say? If this screening test identify 100 people as positive, okay, what? 90 people will be really, what is the answer? 90 people will be really, what is the answer? Positive. Okay, 90 people will be really positive, right? When the screening test say 100 people are positive in the screening test, but really 90 will be positive, right? So similarly, if you say, I'll just put a random number, a negative predictive value, you get a negative predictive value is equal to 85. What is meant by this negative predictive value 85? Anyone? What is meant by this negative predictive value 85? Anyone? What's meant by negative predictive value 85? Okay, we'll see. So negative predictive value means D over, what do you need to have? C plus D. So in the case, how do we need to say that? If this screening test claims 100 people as negative, 85 will be really negative for diagnostic test. 80 will be negative for diagnostic test. Clear? So 80 will be negative for diagnostic test. Okay. Now here. So now you may have a confusion. We also do the calculation vertically and we also do the calculation but horizontally as well, right? Horizontally as well. So in that case, there's one of the easy way to remember this here. The sensitivity, we do it for true positive. Do you agree with me? It is for true positive. Specificity is for true negative. So what is the one of the easy way for you to remember? Sensitivity is for true positive. This one is for true negative. So sensitivity and specificity are for true things. Sensitivity and specificity are for true things. Now there is a confusion what whether sensitivity is for A or sensitivity is for D. What is the easy way to remember? I will put the full screen mode. What is the easy way to remember? Here you can say sensitivity. If you consider sensitivity, this also S, this also S. Here you can see E, here you can P. Which come first in the alphabet? E come first in the alphabet. P come later. A come first in the alphabet. D come later. So that sensitivity is for A, and that A is true positive. Specificity is for D, and D come later, so that is for specificity. That is for specificity, right? That is for specificity. Okay, so that's the mnemonics you can use. Mnemonic you can use. Now we'll come to I think Oshanali, right? Okay, you are Oshanali. So you are drawing something here, right? I don't know whether you or your child, right? Okay, you are drawing something here. So right, okay. So in that case, here you can see when we say sensitivity and the false negative, we will total sensitivity. I am putting a abbreviation SN, false negative FN. And when we total sensitivity and the false negative, what do you get? Sensitivity is 90 and false negative, right? When we say false negative, which is false negative, so this is false negative, so that is 100. Specificity, so this is specificity, and this is false positive, so that specificity and the false positive 100. So what is the easy way to remember? That is constant. What is the easy way to remember? This N, this is also N. Sensitivity N, false negative N. So these two together. Specificity P, false positive P. These two together. So that now, if you want to reduce the false negative, what do you need to do? Anyone, can you put it in the private chat message? If you want to reduce the false negative, what do you need to do? What do you need to increase? In this equation, we have seen that this is constant. This is constant. So if you want to reduce the false negative, you have to increase the sensitivity. This is one of the famous questions. This is one of the famous questions. In some circumstances, we will be discussing that later. We will be discussing the later. If there is a circumstance where you have to reduce the false negative, what do you need to do? You have to increase the sensitivity. If there is a context where you need to reduce the false positive, what do you need to do? If there's a context, you have to reduce the false positive. What do you need to do? You have to increase the specificity. You have to increase the specificity. Okay, you have to increase the specificity. Okay, so we will discuss further, right? We'll discuss further. Now we have learned this. Now let's see what may be the consequence of. We'll see what may be the consequence of the false positive and what may be the consequence of false negative. So in the false positive, what do we say? When a person is not having the illness, we are claiming that you are having the illness. When a person is not having the illness, if you claim that you are having the illness, what sort of consequence will be there? The person will develop unwanted stress. So assume that a person is not having the COVID, you are claiming that you are having the COVID. A person is not having a cancer, you are saying that you are having the cancer. What will happen? The person will have unwanted stress. And there will be unwanted resource usage. can anyone tell me why there would be unwanted resource usage when there's a false positive? When a person is not having the illness, if we claim the person is having the illness, why there would be a unwanted resource usage? Because the person should subject to the diagnostic test. And if the person has to subject to the diagnostic test, what sort of costs are there? Lot of costs are there. The person should be away from the work. That cost is there. The person should travel because the diagnostic tests are not available all the places. Because that will be in some specific places. The travel, the diagnostics may be costly, right? So like that, there are a lot of resources, and the diagnostics involve highly technical people. So you will be utilizing the time and resources of highly technical people. Sometimes CT scan. The CT scans need a lot of resources. So in the case, what happened? Other thing, you expose the person to diagnostic test. Because there are also some harmful consequences of diagnostic tests. What are the harmful consequences of diagnostic? Some tests may be invasive. You may have to take a liver biopsy. You may have to take a renal biopsy. And some tests you may have to expose to radiation. Right? Radiation. So like that, exposed to diagnostic test. And the diagnostic test may be some really limited resources. So you may be utilizing the limited resources, right? So unwanted resource usage. So these are the consequences of false positive. So that in some exams and some questions or many questions, they expect you to know the consequence of false positive. So you should be thoroughly about that. What is the other one? False negative. So what is false negative? When someone is really having the disease, you are saying you are not having the disease. So for example, when a person is having a liver cirrhosis, if you say you are not having the liver cirrhosis, what will happen? The person will again directly go to Santosin to celebrate the person is not having the liver cirrhosis. The person will directly go to a liquor shop, not there. Right? So you are giving what? Two consequences are there. One is you are missing the early diagnosis, and you are giving the false reassurance. Right? You are giving the false reassurance. Both are consequences, harmful consequences. Right. Now we'll come to the situation, right? Now, just these things I have already discussed, right? The sensitivity, how do we calculate everything we have discussed, right? These things we have discussed. We'll skip that. So that what are the consequences of false negative? So that you are giving a false reassurance. Say, for example, in a COVID situation, what may be the, because you may get question, the discuss the MCQ involving what? What are the consequences of false negative screening test for COVID? Can anyone put in the chat message? What may be the false negative consequence of COVID? What will happen? You are failing the chance of diagnosing the person, so that the disease will spread. The person may go into complication, right? So you are losing the chance to confine the disease, right? Missing the opportunity. So all these things will be there, right? Okay. Now we'll come to the other aspect. Okay. When you consider resources, what aspect you have to consider in the resources? And usually there's a mnemonic: men, money, material, miles, minutes, methods, like that. Many M you can see. So I'm not a gender biased person. You can also say men and women, but it's easy to what? Recall, right? Okay, these are the resources. Now, this one we have discussed. This one we have discussed, right? Okay. So sensitivity and specificity we calculate vertically, and these decisions are based on diagnostic finding. So these are more constant. And the positive predictive value is affected by prevalence. So you may get a question whether positive predictive value is affected by prevalence. Yes. Negative predictive value is affected by prevalence. So if the prevalence is higher, what will happen to the positive predictive value? Whether positive predictive value will increase or positive predictive will reduce. If the prevalence increase, what will happen to the positive predictive value? Anyone? Anyone? It will increase. When the prevalence increase, positive predictive will increase. Why? Because when the prevalence increase, what will happen to A? A will also be increased. We have already seen what is prevalence. A plus C. So A plus C. So when the A increase, what will happen? This one also increase. Say for example, say you assume what? Among the higher age group, if you say you may be positive for hypertension, likely the person may be positive for hypertension. But among the school children, if you go and say you may be positive for hypertension, but unlikely, like that. So that, you know, the people who get Shastra, you know, in front of the hospital, there are many people who are selling Shastra, no? How do you tell Shastra? They look at the face, the person is very happy, they tell some happy plus and occurrences. The person is sad, if it is a medical student, your boyfriend has given up you, right? So like that they will tell. Okay. So what will happen? When the prevalence reduces, the negative predictive value will be increasing. Because if the disease prevalence is less, if you say the disease is negative, likely your answer will be correct. If the prevalence is higher, if you say, right, nowadays, if I ask among the people who are attending here, you are likely to sit for an overseas screening exam. Likely my decision will be correct. Why? Because chances are more among the people who are joining this class, right? Like that. If I say that it's unlikely you will stay in Sri Lanka, in that case, what will happen? My negative predictive value will be higher, right? It's like that, you know. Okay. Now we'll come to this one. This is explaining about the false positive and the false negative. So here what happened? So we will skip that. We'll skip that. This may not be required at your level. And we'll come to the trade-off between the sensitivity and the specificity. In some circumstances, we need to keep the sensitivity higher. In some circumstances, we need to keep the specificity higher. But the thing is there, if the sensitivity increase at a loss of what? Specificity. If you want to increase the specificity, it is at the compromise of what? This one. So in that case, I have to stop sharing and again I have to come. So the yellow marks. So I will share it again. Can you see that now? The yellow marks are gone. So the sensitivity, right? The sensitivity. So that what happened? If you want to increase the sensitivity, what will happen? The specificity may go down. So that is something like that. Say, for example, if you want to find a partner with a very high dowry, in the case, sometimes you may lose what your criteria for education. Sometimes your future partner may have studied only O level, isn't it? Sometimes you want to find a partner, you get a first class. In the case, what happened? You may have to have a trade-off between getting the dowry. Sometimes the person who is getting the first class may be very poor. So like that, right? You may have to have a trade-off, okay? Right, in that case, so here we say, already we have seen, here we have seen that, this one. Sorry, I'll show that. When do we need to increase the sensitivity? If we need to reduce the false negativity. When do we need to increase the specificity? Whenever there's a need to reduce the false positive. So we'll see the situation, right? We'll see the situations, right? So for example, right. So we'll see that, right? So when do we need to increase the sensitivity, right? So when do we need to increase the sensitivity? When there's a need to reduce the false negative. False negative. False negative. That means when a person is having the disease, we should not tell them as negative. That means missing the diagnosis is more harmful. So in that case, here, for example, phenylketonuria. In a phenylketonuria, we'll tend to have high sensitivity. Why? The condition is very serious. There's a cheap diagnostic test. And even if you diagnose, if you alter the diet, the chances of improving the quality of life is better. That, say for example, syphilis, right? And also what happened, there are many other conditions, right? Okay, many other conditions. So in the case, what will happen, we want to increase the sensitivity, right? Okay, so now we'll come to this one, right? Right. So when do we need to increase the specificity? So when do we need to increase the specificity? Whenever we need to reduce what? False positive. Whenever we need to reduce the false positive. What is the consequence of false positive? Either the stress may be more, either the diagnostic cost may be more. So in those circumstances, what do? We want to reduce what? The false positive. So for example, breast cancer. So when we consider the breast cancer, because the stress is higher. When you say a woman that you are having breast cancer, but the stress is higher. Other thing is there, the cost, diagnostic cost is higher. You are subject into biopsy and like that. In those circumstances, what do? We increase the specificity, right? So in that case, there's another aspect there, the combination of tests. You may also get some questions which are relevant to combination of tests or multiple screening test. Combination of test or multiple screening test. Now we'll have a look the combination of test. There are two methods are there. One is parallel testing, other one is series testing. So you consider the love affair among the university students. Some people follow the parallel testing, some people do the series testing. What is meant by parallel testing? The same time they will have more than one partner and try to manage more than one in the university, one in the village, and one among the relative, like that, a different place, different partner, and ultimately decide choose one. One is series testing. Those are serious people. Find one partner, when it fail, go to another partner, like that. Okay. So the parallel testing. In the parallel testing, what do? All are administered simultaneously. When you have more than one screening test, you apply more than one screening test simultaneously. And when we consider the positive results, when do we consider a test is positive? When we do parallel testing, if any test is positive, we consider it as positive, right? Any test is positive, we consider as positive. So this what happens, increases the sensitivity. If one test is missed, at least another test picks up. If one test is missed, another test, so that increases the sensitivity with the individual test compared to the individual test. Rather than having an individual test, when we have a parallel test, the sensitivity of the parallel test will be more when compared to the individual test. These can be simply asked in an MCQ. Okay, in parallel testing, sensitivity will be higher when compared to the individual testing, but specificity would be lower when compared to the individual test. I have already told you, because there's a trade-off. If you try to increase the sensitivity, that is at a cost of what? Compromising the what? The specificity. Say, for example, deep vein thrombosis, right? Deep vein thrombosis. The Sri Lankan students, you may not have seen much deep vein thrombosis. Those who have done the overseas, mainly in the Western world, you may have come across the cases with deep vein thrombosis. So in the case where you can do impedance plethysmography, or you can have a lead scan. So in the case, you pick up what? If it is positive, at least one, you consider as positive. So this is parallel testing. Now, what do we say? We consider the series testing, right? When we have the screening test in series. So when we do the test in series, the initial screening test is administered, right? Okay, we do the initial test, and only the persons who are positive for the initial test are subject to do the another test. So that what do we want to do? Sometimes the initial test may be a false positive. We subject to another screening test and what improving the chance of being positive, right? Okay, so that what happened in that way, what happened? We increase the specificity when compared to the individual test. But when compared to the individual test, what will happen? The sensitivity will be lower. Say, for example, mass screening of syphilis. Mass screening of syphilis. What do? Initially, we subject VDRL test, or initially we subject rapid plasmin reagent. And then what happened? We do the other test, right? So, for example, if you get an MCQ, if a patient is positive for VDRL, what do? You get an answer, we repeat VDRL, true or false. We repeat VDRL, true or false. If a VDRL is positive, the answer is we repeat VDRL. False, because it's a screening test. It's a screening test, right? Okay, it's a screening test. So we don't repeat, right? Now we'll come to the other aspect, right? We'll come to the other aspect, the testing in series, right? The summary about testing in series. So we run several tests sequentially, as the name indicates, series, and every test that runs positive, we classify as positive. A true positive is determined when each test is positive. The advantages that improve the what? Overall positive predictive value and also specificity, right? And when we consider the other one, that means my mouse is not supporting, we'll see, right? Okay, testing in parallel. When we do the testing in parallel, that means we do the test simultaneously. Every test that must be negative to classify something as negative, right? Okay, so a true positive is determined if a single test is positive, and the negative is determined when all the tests are negative. So by that way, what happened? We improve the specificity, right? Okay, so then I think I have put a typo, right? Okay, so we'll come here. So there is a mnemonics. You can use a mnemonics. Here you can see a mnemonics. That means the parallel testing improves the sensitivity, and series testing improves the specificity. Okay, parallel, series, P come first in the alphabet, E come first in the alphabet. Series, S come later, P come later. So parallel testing increase the sensitivity, and series increase the specificity, right? Series increase the specificity. Okay, I think this is a last slide, but someone asked to explain about all right. Okay, here this is a summary that you can see here. In series, when do we claim positive? When both more than one test are positive. In series, when more than one test are positive, we claim positive. In parallel, when do we claim negative? When more than one test are negative, we claim negative, right? Okay, we claim negative. Okay, so in the case, what happened? Your specificity will be better, and here your specificity will be better, and here the sensitivity will be better. Okay, right? Okay, so and the reliability of screening test, right? Reliability of screening test. So what aspects are involved with the reliability of screening test, right? Okay, so number needed to treat, that's coming under the another topic, not under the screening test. So that is coming under the clinical trial. So that if I teach clinical trials, so then I can cover that. Otherwise, if you want to learn your own, so you can check under the clinical trial. Okay, so we'll see here. So one thing, biological variability, right? When you consider the reliability, right? Okay, so when you consider the source of unreliability, what are the source of unreliability? One thing is biological variability. So for example, when you consider the blood pressure, right? When you consider the blood pressure, then you can see time to time there can be biological variability, right? And with the person's exercise, stress, it would vary. Instrument variability, right? Depending on the device, there can be variability. Intra-observer variability. Within the same person, right? When you perform in the morning, when before you finish your work, it would vary. Inter-observer variability. So between two people, there can be variation, right? Okay. So that type of variation would be there, right? And right. And then what are the measures to minimize the inter-observer variability, right? So how we can minimize the inter-observer variability. So making the endpoints well defined. Say, for example, if you are checking the blood pressure, whether it is a muffling of the sound or disappearance of the sound. So like that, you can define the endpoint very precisely, right? And also what you can do, you can have some objective criteria, right? You can have some objective criteria, right? You can have the objective criteria. And what sort of adverse effects, right? So false negative can be one, positive can be one, and the over-diagnosis. Because when you over-diagnose, what will happen? Again, the system may not have the capacity to treat all the people, right? Okay. And the evaluation of screening program that we can skip, these things we can skip bias. Because the other important thing in the bias is, I'm concerned about the time as well. Other important thing in the bias, the three type of bias are common, right? Three type of bias are common. One is self-selection bias or volunteer bias. Other one is lead time bias. Other one is length bias. Okay. Self-selection bias, lead time bias, right? Okay. And the length bias. What is self-selection bias? Because if the people who participate in the screening systematically, the word systematically is very important. Systematically differ from the others. Say, for example, some screening tests, say breast cancer screening. If you want to do breast cancer screening, there are two likelihoods are there. Sometimes the people who had close relative having the breast cancer may willing to join. There is one sort of bias because the people who are at a high risk are more likely to join the screening. Sometimes the people who have good habits, they have less chance of getting the disease, but since they have less good concern about the health, people with less likelihood of having the disease may join. Both may have bias with the screening. So that is called volunteer bias. So if healthy volunteer to do, what will happen? You will have less case detected. If high risk volunteer, you will detect more people as having the disease. Okay, right. Now we'll come to the this one, right? Okay. Now we'll come to the, sorry, because my mouse is not much supporting. Right, lead time bias. What is meant by lead time? So already we have seen what is meant by lead time, right? That means here in the detectable preclinical phase, we diagnose the condition. And if this is the usual diagnosis, so this is survival time with screening, survival time without screening. And this is the time with the screening. So that is called lead time. So when there will be benefit, if you screen, if this is moved this way only, you have benefit. If you detect, the prognosis should be improved. If the prognosis not improved, you will think the people are living longer, but ideally they may not be living longer. Both may be dying at the same time. Only thing is you may have detected them some early. Ultimately, they are not getting benefit. That is called lead time bias. When do you get a lead time bias? When you do a screening, and if you can't improve the prognosis of the person, and you may see that the person is living longer, but ideally they are not living long. That is called the lead time bias. Okay, lead time bias. Other one is the length bias. Length bias. What is meant by length bias here? Some illnesses are having short lasting. So here you can say this is short lasting. This is short lasting. Here you can see this is long lasting. So in the case, if you put a screening here, the long lasting one, your high chance of detecting them. And the short lasting one, less chance of what? Detecting them, right? So in the case, if the disease is short lasting, then what happens? You have to screen in a shorter interval. Say, for example, pap smear. If the pap smear is negative, after how long? If the pap smear is negative, after how long they give an appointment to come for the repeat smear? Anyone? Pap smear, if it is negative, after how long? 5 years. Usually 5 years. Usually 5 years, right? Usually 5 years. So why do they give that longer time? Because the detectable preclinical period is very longer. But you can't do that with a very short-lasting diseases, say esophageal cancer, lung cancer, so that you can't do. So that is called, how do you call, length bias, because the length of the detectable preclinical period differ, right? So these are the major aspects we need to discuss, and within whatever, because you know that the screening test usually for MD people, I do that sometimes the entire day. So there are a lot of aspects to discuss, right? So that we can't discuss. Actually, I target to do that only 1.5 hour class. But within whatever I have discussed, if you have any doubt, you can ask. Not the new thing, right? Okay. And if you have fallen asleep, during the class, or if you were to feed your baby, or if you were to share a pizza with your girlfriend, and that's why you have missed the class, I can't repeat, you know. Okay. So what I want to say is the screening test is an interesting topic and one of the good topics for exam questions, so that there are some principles, you have some understanding rather than memorizing. What do? You understand the basic principles, and there are some mnemonics, and try to use the mnemonics. So when you use the mnemonics, facing the exam would be easy. Do more and more questions, so that right, do more and more questions. Okay, so I think we can wind up. Thank you for joining, and I appreciate your interest in learning statistics and epidemiology. Okay, thank you very much. So I will leave from the session.